Hello and welcome to A Health Podyssey. I'm your host, Alan Weil. We're recording this episode on a really important day. It is our 200th episode. Oh, did I mention it's also Election Day? I guess you can decide which of those is more important, but we think it's a pretty important day here at A Health Podyssey. In all seriousness, I want to thank you, our listeners, for tuning in and spreading the word about the podcast. I now have the reasonably frequent experience of meeting someone who says, hey, I recognize your voice, and this is where they've heard it. And I want to give a special shout out to Jeff Byers, who's our producer and has been from the beginning. He operates largely behind the scenes, but not only does excellent production work, but really guides us in the entire endeavor. So thank you to Jeff. So the question is how to celebrate this milestone, and it just happens that we had a great 100th episode, so we decided let's invite back our guest from the 100th to be our 200th, and that's Leemore Dafny. Dafny is the Bruce V. Rauner Professor of Business Administration and the Mary Ellen J. and Jeffrey J. Fellow at the Harvard Business School and Professor of Public Policy at the Harvard Kennedy School. Just last month, Dafny was elected to the National Academy of Medicine, and I will quote from the election materials for her path-breaking work in illuminating where healthcare markets succeed and fail, including powerful insights regarding market consolidation, strategic decisions of market participants, and policy solutions to market failures. So most weeks, we talk about a specific paper that Dr. Dafny might have written if she were our guest today, but we're not going to do that. Instead, we're going to discuss a topic that may not sound as interesting as it is. The topic is vertical integration. It's about how hospitals are buying up physician practices, and physicians now work for insurers, and how the whole supply chain is owned by fewer and fewer enterprises. Traditionally, antitrust regulation is focused on horizontal consolidation. If all the doctors in a city get together, it's pretty clear that there are anti-competitive effects. But vertical integration has not been viewed as much of a threat, and it hasn't received the same level of scrutiny. So we're going to spend our 200th episode discussing this complex and critical issue with someone who I could think of no one better to have the discussion with. Dr. Dafny, you're now a regular on the program, so if it's okay, I'll call you Leemore. Welcome to the program.
Thanks so much, Alan. I'm delighted to be here at this, I don't know if you want to call it a centennial celebration.
Bicentennial, I think.
There you go. Okay, bicentennial. And let's just hope that this conversation is as enjoyable as they always are.
Well, I'm not too worried. Okay, so let's get off to sort of the evidence-based start. We're always starting with the evidence here. I just gave the truly skeletal outline of what vertical integration or vertical consolidation is. What are you seeing out there? What makes you view this as a topic that warrants an entire podcast episode?
As you mentioned, a lot of the focus historically, both by regulators and I would say by, observers and researchers, has been on horizontal integration, which is when entities in the same market combine, and that market has both geographic and service boundaries. So it's when rivals combine, they're no longer competing. And as you mentioned, it's pretty clear to see the risks associated with that. And there's been a lot of documentation, a lot of cases brought on horizontal integration. And to some degree, the industry hit a kind of its limit, not completely, because there's still plenty of subsectors that are horizontally consolidating, and there's been growth, especially in consolidation of physician practices, and private equity involvement in that is much talked about. But because the horizontal integration, certainly among the large players in any given sector, is hitting its limit, there's been, I think a lot more looking around for partners that are up and down the value chain. And so we're hearing a lot more about vertical deals. It's also the case that historically the antitrust enforcement authorities haven't challenged or even necessarily that closely scrutinized these vertical deals. And while that is changing and has changed in the last couple of years, it's a safer bet, if you will, if you're a corporation that wants to grow, to look vertically than to look horizontally. And I should also mention, because I'm a teacher, so I want to be thorough here, that there are other kinds of consolidations that are neither. And so I often will, like a lateral consolidation. So, for example, hospitals that are merging with hospitals in other markets, same product market, but different geographic markets. And we are seeing a lot of that to what I call cross-market mergers.
Now, I spent time on the Commonwealth Fund's Commission on a High-Performance Health System. I've been around long enough to remember managed competition. The model proffered by many over literally decades is that we should all be in vertically integrated systems. We should pick an insurer who sort of organizes the system for us. And yes, we should have a choice of carriers, but that basically they should be competing on the entire spectrum, and we should have choices among them, and that would be how a market would work. So that sounds to me, and sounded for decades, like a pretty positive story. On the one hand, you've got fragmented fee for service, and no one wants fragmented. And on the other hand, you have integrated, capitated systems that can compete. So how do I understand what's happening now with respect to sort of the positive story of we can be more efficient, all the sort of normal supply chain kinds of things, versus the opportunities for financial gains or steering or coding or all these other kinds of things that having control over might open up for you? I'm just trying to figure out sort of what's underlying this.
I'll do my best because it's a really big puzzle. Let me say first that vertical integration is a blanket term for any combination up and down the value chain. And we have seen a lot of vertical integration of delivery functions, in particular hospitals acquiring physician practices, which I want to speak about in a moment. So let's park that for a minute. We've seen some, especially when it comes to United Healthcare, acquisition of especially non-hospital assets, provider assets by an insurer. So that's one kind of insurer-provider integration. What we have not seen that much of is that Alan Enthoven dream. And it's a dream that I've held on to also. And I'm, I won't even say I've given it up because, I want to believe that we could get to that kind of model somehow. However, we have not seen these vertically integrated models competing with one another in a way that seems to generate lower prices. And there isn't evidence, I'm sure you're aware, that the vertically integrated plans deliver better care. Now, there may yet, such evidence may yet come out. However, conceptually, given all of the potential advantages of being able to manage the entire care continuum and the potential to eliminate a lot of administrative hassles associated with that, not to mention the fact that the leading vertically integrated delivery plus insurance systems have enrollees that have really long tenure with those plans, and therefore the payoff from prevention is present. Given all of those advantages, you ought to think that they would clearly be better and clearly be much cheaper. And I've not seen solid evidence to corroborate that. So why aren't they winning? Well, they're not only not clearly better, they're not cheaper. And then finally, it's important to note that not everyone wants a restricted network. So there is a big market. I had a Kaiser executive once tell me that in the Northeast, we are addicted to choice. And I thought that was a very interesting way of observing it. But yes, indeed, if in some parts of the country we place really high value on being able to go somewhere else if we don't like what we're hearing or we don't like how we're being cared for, then in those parts of the country, you're not going to see that kind of system take root unless there are a bunch of options and you can switch. And given how substantial an undertaking it is to build an entire delivery system like that, and I suppose the rewards are not sufficiently great, we haven't really seen it. Now, maybe Risent, which has been formed as part of the acquisition of Geisinger by Kaiser, will be able to grow these kinds of plans more. I would welcome that. But so far, that idea has not been one that has ended up having that much of an impact broadly in the U.S. market.
So that then raises the question of why are we seeing this? And some of the negative stories come to mind, I think, and here it gets really complicated, as if it wasn't complicated enough already. These systems have public payers and private payers. And we know from all of the research we've done over the years that what's driving high costs on the private side is prices, and what drives higher costs on the public side, because prices are set by regulation, is utilization. But then you have opportunities to increase payment levels because we don't have site neutral payments, and we have potential steering of patients. So what I'm trying to get my head around is sort of how much have we created a system of complexity with different payers and different payment models that make this kind of vertical ownership primarily an opportunity to, maximize revenue, either drive up prices or drive up volume or drive up intensity, the kinds of things that get you more money, which is a very different story than the Entovian let's all be more efficient and compete on how efficient and streamlined we are. This is sort of the opposite. So how do you see that side of what's happened?
So before we talk about the games that vertically integrated systems can play, a word on what would be required for the dream of vertical integration to come to pass, where that dream involves passing through some savings, as well as high quality to consumers. And it requires two things. It requires competition, right? Otherwise, you're not going to be able to strive to be the best when you're the only game in town. It also requires demand side price elasticity. So if you are insensitive to the total costs that is being charged, what do you expect the suppliers to do? They have workers, they want to pay their workers, they would like to invest in the latest equipment and provide the best medications, et cetera, et cetera. And let's not forget that the leading vertically integrated delivery systems with insurance companies, the only ones I know of, are not for profit, right? So they've got pretty complex objective functions. So without competition, without demand side elasticity, we're not getting the dream. And then maybe we'll have a moment to talk about ICRAs at the end and whether that could help us achieve that dream. But you asked this question about whether current vertical integration is actually enabling gaming and kind of making the problem worse. And I will say that to turn to the research is pretty clear on that from the hospital physician side, that the non-neutral site payment has led to a lot of higher prices and spending and consolidation. 340B appears to be a contributor to this, certainly for some specialties. And we've also seen that when physicians have ancillaries like imaging, that leads to more spending and does not lead, interestingly, to improved quality or access even. There was a great health affairs study on that by, I think, Lauren Baker and others. So that is not optimistic. If we turn to what about the insurer acquisition of different kinds of healthcare providers, that's where the literature is a lot more silent. And I've been trying myself I'm looking at, it's 2024. I've been trying myself since 2016 to study this, and it is increasingly difficult for researchers to get a hold of claims data with identifiable providers, let alone the insurance of the claimants. And so it's just, and the prices. So we don't have good answers on what happens. I can give you a list of things that are both good and bad that could happen. And it's a little frustrating. I know of some projects, even one I'm working on, that maybe will come out in a year or two. We'll have a clue, but it's not been easy for us to assess what they're doing here.
So this is sort of the puzzle I feel, well, there are many puzzles in life, but here's the one that I'm focused on today. There is a story that is the story actually that underlies the historical lack of attention that antitrust has given to vertical, which is that there are opportunities for efficiencies. There are opportunities for clinical improvements, including clinical efficiencies, but also administrative efficiencies, that you can tell sort of a quality efficiency story as you build these vertical systems. But in order for that to have price advantages or consumer-facing advantages, it needs to play out in a world where competition makes those systems perform better and pass on the efficiencies that they create to the payer. And in the absence of that, we get all the same outward activities, the consolidation we see, but rather than these potential benefits, we get these harms. We get higher costs, higher prices, directing people to services that are more expensive, leveraging discounts. So maybe it isn't a puzzle. Maybe that's just the truth. But I guess the puzzle is it possible then to look at where we are and say, we could get from where we are to a place where we could get the benefits without some of these harms? And I wonder if you could give me some thoughts about, maybe it's just impossible, but some thoughts about how we might just take where we are as a reality. How might we look at it and say, let's put some things in place that we think are likely to reduce the harms and increase the prospects for benefits for patients and payers?
That is a giant question, Alan, and I want to give you an optimistic answer, and I'm going to do my best. But I'm a dismal scientist, so I'll caveat and first just mention one note about the potential positives of vertical integration. As you're aware, hospitals are responsible for a big chunk of the service price growth that we've been experiencing, and the use of expensive sites of care and so forth. And therefore, doing something to address the exercise of market power by hospital systems is important. And short of price regulation, which I'm about to bring up, the acquisition of other like ambulatory surgery centers or healthcare providers by insurers is a way to potentially be a counterweight to those hospitals. You could say, I have my ambulatory surgery center. I know what the costs are. This is what we would pay and what others pay us for. This is what we are willing to pay you, hospital, for your HOPD. So I do think that there is the potential to be a counterweight and offset offset some of that market power. So that is one kind of feather in the cap, if you will, for that sort of integration. We also know that the insurers are buying up providers except for hospitals. So they're treating the hospital as the cost center that it is. And that is probably going to drive any kind of hospital-focused system to be a little more efficient. And I'm sure that you're thinking to yourself about the result that accountable care organizations tend to save more money when they don't have hospitals involved. So observing that there are some benefits that are possible with that form of integration, but it's going to require the downstream to have budget constraint, right? And not be keen on paying for increased spending, which is also possible, particularly through the mining of records to change codes and garner higher payment. Okay, you asked this question of can we get to where you and I and many who are schooled in health economics are hoping we could go, which is an aligned provider insurer that is, seeking the highest quality, controlling for the cost, if you will. And I think there are a couple of possibilities, right? One is increasing the elasticity of downstream demand such that we are voting with our feet. And that is what I foreshadowed earlier with the ICHRAs, where you are buying an insurance plan. And if you are willing to take on a plan that has a high performance network, okay, that is restricted choice of providers, then you will get some kind of benefit and use your employer provided tax dollars to support the purchase of that plan. I think that will get consumers voting with their feet, and that will place some pressure on providers to focus less on price and more on what they're delivering to patients. That's one. A second is the possibility of some kind of, and this is for the commercial market, price regulation of services that will enable the price points to come down and reduce the incentive to play games, right? If there's not as much of a reward to provide care, right? In fact, if you don't even like the idea of price regulation, I don't like the idea. I'm an economist, okay? I didn't say setting prices. Mike Chernew and I and Max Pani have a proposal about setting a price cap, which we would prefer. But you could also just do site neutral. That will even start the process. So I think that will help. And last, I do think it could be possible, just like the HMO Act of 1973, I think it was. You think it's 83? 73.
I think 73 is right.
Okay, that's I don't want to say it. Okay, but 1973, a very special year, basically kind of forced HMOs down the throats of employers, large employers. I think it is conceivable that we could force offering more choice and meaningful choice down the throats of large employers. And that is the only way for there to be demand responsiveness. So that's the best case scenario, I think. And it may be something that I was writing about the last time we spoke on the podcast.
Well, great. I want to take this a few steps further and figure out, I like that you turned us to a positive trajectory on a difficult subject. I'm going to ask you a few more questions about how we get there after we take a short break. And we're back. I'm speaking with Leemore Dafny about vertical integration. We've had a great conversation about what it is and the risks it poses. But thankfully, you turned us toward a more positive scenario. What would it really take to have these integrated systems be the ingredients of a more efficient overall healthcare system that, when it generated those efficiencies, also returned the value of those efficiencies to the purchaser, and purchasers sure are ready for that to occur. It did make me wonder about the complexity we have now around different payment models. We talk a lot about capitation and alternative payment mechanisms. You mentioned ACOs, which are sort of, risk sharing. We know from the literature that even systems that at the top level are capitated tend to still pay on a fee-for-service basis once you get past that top level. But I'm trying to imagine a world where capitation really meant a little bit more what we think it means. And these opportunities for gaming, I'd like to think would be diminished. They wouldn't be eliminated. For example, capitation payments are risk adjusted. And if there are ways to game risk scoring, I suppose you can still do that. But I do wonder if part of what we're seeing here is this middle game where no one's quite sure how far the capitation process is going to go, but there are enough places where it's out there that this is sort of anticipatory. We need to be the whole supply chain so that we're ready for that. But because the payers aren't there yet, we're kind of mucking around. I don't know. Does that make any sense to you?
It's a super interesting question. It definitely makes sense. And I'm, off the top of my head, a couple things come to mind. One thing that comes to mind is that until we have a tipping point and basically your payers are willing to give you risk as an integrated delivery system, it's extremely difficult to imagine that you can get away from fee-for-service. And if they got there, then I would expect that a salary type model, sure, with some kind of productivity elements, and you can do some of that, but not this eat what you kill kind of model stuff. I think that right now our prices are very broken, and clearly, state something that your audience all knows. But clearly, we have far too many specialists relative to primary care providers. And even in the last couple of years, when I asked system executives, why don't the primary care providers get compensated more so that we have a shift in the market toward them instead of toward the expensive specialists? And the answer is because I can't bill them out for more. So, clear evidence that the shift toward quote value-based care is not working its way through the prices and the compensation, and that matters. Okay, we're in a capitalist system; it matters. So until we can get to more risk bearing, such that the organization then effectively is paying salaries, it's hard to see that we get that right. And then I was going to tell you a little story that I think is related. That came up when you were asking this question of how can we get to a point where if you pay one fixed sum that we will get the desired outcomes, i.e. we're not paying piecemeal in a way that gets us just like the random stuff that piecemeal will get you. And the story comes from when I paid a visit to Kaiser Permanente back when I was probably junior faculty with a group, and we were led around in Oakland by wonderful host Murray Ross. I learned something that made me quite sad, which is that Kaiser at the time had not had any prices. They just didn't have prices. What they did is they employed physicians. They had, sites. They purchased supplies, but they didn't figure out, how much do we quote charge for this outpatient visit or for that procedure. They did stuff. Okay, which I think is central to anything that actually works as we're talking about wanting it to work. Obviously, you ought to know the opportunity cost of resources. So I'm not saying there's no place for price, but they said, what we had to do once high deductible became in vogue is we had to attach prices to things because we couldn't compete in the insurance market without offering high deductible. But then we had to make up prices for all the stuff that you might have done. And then we had to start collecting those dollars and so forth. And thinking about the administrative costs and just the idea that the prices were not being constructed for some purpose like figuring out opportunity costs, but rather for this insurance market, shift toward greater deductibles. I found that kind of saddening, and it explains we've layered a lot of administrative costs on our entire system, and that's another reason that, until we get a shift where that's not the way that reimbursement is done, it is hard to get to our dream, Alan.
Yeah, I had not heard that story before, but it certainly makes sense to me. And it really, I guess it just refers me back to my question, which is, could we achieve a tipping point? And maybe individual purchase, which has been held out for a long time as the way to bring more discipline to the market. And yet, here we are. But is there a realistic possibility that in an individual purchase market with enough subsidies that people can actually afford real health insurance, you see the emergence of significantly lower cost systems that eliminate lots of this other junk, but are actually quite attractive to a sizable share of the market? You could imagine some of that happening in the ACA marketplaces, which have a higher level of price sensitivity than your typical, although again, most people are subsidized, but you have competition at the bidding level. So, all of these are the question of, could we generate a marketplace where, as you said, the two ingredients that are missing, you need choice and you need price sensitivity. And if you could do that, then some of this vertical integration could be the foundation for some super efficient, desirable products. And our listeners can't see you smiling, but I'm afraid that smile is a little bit of a, yeah, right, Alan. But maybe we find our way there. Okay, so given that you're not going with me here, I know I could talk to you all day. Let me ask a really obnoxious question. It's one that I think about a lot on this topic, which is, I spend a lot of time with people. Discussions of consolidation are everywhere now, and there's a very broadly held view. It's not really partisan, that we've sort of gone too far in horizontal consolidation, that there are very few systems out there in most markets. And we kind of, in some respects, it's too late. We can look for ways to slow the additional levels of consolidation. We can look at certain sub-markets that are not yet consolidated and try to prevent them. But fundamentally, there's just been so much. I guess my question to you is, would we think differently about vertical integration if we weren't so far along in horizontal consolidation? Would it be easier to envision? I mean, United is an easy example here. If there were multiple vertically integrated systems playing with, making arrangements with, and potentially owning multiple physician practices. I know you said hospitals aren't part of the vertical chain right now, but you could even imagine in that world that they would be. Would we think differently about vertical if we weren't so far along in horizontal? What do you think about that?
I think we would. I think one of the big risks associated with vertical is what the antitrust folks call foreclosure, where that means you foreclose your rival from access to an input that you own in your value chain. And if that input, it could be a certain type of specialist, if that input is one where there are a lot of alternatives in the marketplace, then you aren't foreclosing anybody. You're competing as an integrated entity, so there's a lot less concern in terms of competition. In terms of gaming, there's still that potential, right? There's a fair amount, say, of hospital-physician integration where that hospital and those physicians don't really have market power, but they're charging a lot more because they can, because of the way that Medicare structures its payment, and the fact that the private payers just follow suit. And that also, to some degree, has to do with horizontal integration, because if the insurers were really, really competing, I would have thought they'd come up with some different way to pay instead of just copying Medicare. And they have not. They haven't had to. Downstream is paying what they end up charging, and it's all going along. So in answer to your question, I do think that, right now we're aware, for example, that the Department of Justice has opened an investigation into United Healthcare, which is, a mammoth across a range of sectors. And we don't know the resolution of that. But we know there's concern about it. And if United were, a small insurer, I think there would certainly be less fear.
Well, I'm at some level, I'm happy to hear your answer, but then it also, of course, puts us at a little bit of a dead end because we can't really unravel the horizontal consolidation that we've seen, and therefore it is a bit more of a hypothetical question. But I think it is still it's helpful to understand that answer, because as we think about how to respond to vertical integration, it is important to focus on what dimensions of that integration we're concerned about purely because it's vertical, and what dimensions of it we're concerned about because it's layered on top of horizontal. And we might actually have different policy responses for those two types of problems, even though they both manifest as vertical integration. I don't know. Well, Leemore, I really could talk to you about this longer than our listeners would listen, but maybe not, but longer certainly than you have. You've been very generous with your time. I am hopeful that by bringing these topics to bear at this stage, we can avoid some of what happened in horizontal, where at least it's my view that we let that go too far for reasons that we don't need to explore at the moment. But that by looking at other dimensions, you also mentioned cross-market, which we did not discuss in much detail here, but there are lots of dynamics in this marketplace that people like you are trying to understand early enough in when they occur that we can try to head off some of the problems that otherwise researchers are just studying the consequences of bad things that have happened, and it leaves us in a place with very little to do. So I am very appreciative of being able to spend some time with you thinking about it more conceptually at this stage, in the hopes that it will help you and others think of the right research questions for where we are now, so that we can intervene appropriately now when there's still a long way between here and where we could be. So with those thoughts, I want to thank you for being my guest on our 200th episode. Don't know if you'll do this again for me for the 300th, but I enjoyed it, and I'm really appreciative to have you as part of the show.
Alan, thank you so much. Those were incredibly thoughtful and interesting questions, and I really enjoyed the conversation this time. And I think we should check in around the 300.
Let's do it. Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.